the idea from this that early antibiotics is not a benign thing to give to babies who don't need it. Obviously, if the baby needs antibiotics, the baby needs it. But however, if the baby does not need antibiotics, we have changes in the bacteria that's in the baby's body. Like all of us actually have more bacteria in our GI tract than we have cells in our bodies. So if we change them by giving antibiotics, that's not the normal way things should progress. Also, babies get more wheezing, more inflammatory bowel disease. So giving antibiotics is not a completely benign issue. Okay. In addition, there's each day of additional antibiotic therapy was associated with increase in late onset sepsis, necrotizing enterocolitis, and death. And this is from a study from 2018 in a large neonatal unit in babies less than 33 weeks. So what we found is that if you give babies lots of antibiotics in these small babies, you have increased incidence of late onset sepsis and you see death. And that's after adjusting for other problems with the babies. So the odds ratio is 1.24, which means you're 24% more likely to have all these problems than if you had not received antibiotics. So now we'll go through some definitions. So one of them is nosocomial infection. Now we call it HAI, or healthcare associated infection, or hospital acquired infection. So nosocomial infection or hospital acquired infection is the responsibility of the medical staff. Like if the baby comes to us from mom with a problem, we cannot really do much about that. So now we have the early onset sepsis, which is usually within the first 48 to 72 hours, and that's usually mom source of infection, whether it's a vaginal tract infection or is it a blood through hematologic spread through the placenta. Then there's late onset, which usually is the nosocomial type, and that will be something we can do things about. These are the common bacteria. We all have seen that. So the early is GBS, E. coli. We don't see Listeria much, but it's listed. And then the late onset is the coagulate negative staph, gram-negative organism, candida, yeast. Then late, then you have the multi-drug resistant organism, and these are a problematic things. These are pretty common problem. 36% of death in the neonatal period is associated with infection. So it's a major deal, and it's really important to do whatever we can to minimize the infection. Now, the longer you stay in the hospital, like your baby's typical, you had to intubate the baby. This baby was okay on CPAP. So now you intubated the baby, that will result in higher incidence of bronchopulmonary dysplasia. Definitely prolonged hospitalization because you stopped the feeding and you put them on vent, and then you had to start over again, feeding and weaning, and it results in delayed growth and development. Dr. Evan mentioned about some of the issues related to prematurity in particular, so that's a good case for it. Immature skin, impaired immunity are issues for preterm infants. And that's inherent. We cannot do much. Once the baby is born premature, he's with us. There's not much we can do about it. However, the extrinsic stuff, we can do something. So what did we do for this baby? We give him antibiotics for 5 days to start with. And we put UVC. You guys did excellent. You didn't intubate the baby. You just gave UVC surfactant with Ensure technique. That's great. So you can maybe tell us about the enteral feeds. H2 blockers like famotidine or Pepsid. Probably I don't know about في مصر هل لسه في رانيتيدين ولا اتمنع، لأنه في أمريكا اتمنع الرانيتيدين.
famotidine is used more widely now.
Yeah. هو المشكلة إن اتفضل.
Stopped in Egypt and didn't return. So it's found in pharmacies is very, very few amounts. But Ministry of Health prohibited it until get 100% sure it's safe. So it's stopped now.
Okay. لأن هو المشكلة إن manufacturing of ranitidine بيحطوا فيه substances that are not safe، فهم اتوقف في أمريكا. فهذا يعني الانتاسيدز اللي بتستعمل هنا دلوقتي يا إما بيبسيد يا إما proton pump inhibitors.
We do the same. Yes, we do the same.
Okay. فيعني ممكن لو نعرف البيبي مثلا حط له UVC. How long do you keep the UVC? When you change fluids, how do you do the procedure of changing fluids and connecting your IV tubings to the UVC? These are important issues, and this is related to the organizational issues of the NICU, the space, the design, the nurses, how many are they? Are they trained? Workload? Are they going to do things the quick way or the one that is more meticulous? طبعا لو النيرس عندها 4-5 بيبيات هتشتغل أسرع من إن هي لو عندها مثلا 2 babies. فدي كلها حاجات we can change. The baby being premature we cannot change. Typically for a smaller baby, usually less than 32 weeks, يعني مثلا 25-26 weeks, they get infection, then they get capillary leak, then they have to be intubated and put arterial lines, more lines, then they get edematous and they go into respiratory failure, cardiovascular failure, and if they live, they have lots of problems afterwards. So we're trying to prevent that. Having premature rupture of membranes is a predisposing risk factor. Maternal fever is a risk factor. Together, they make things much worse. Obviously, sepsis rate is different from different places, from different countries. You need to see what your sepsis rate in your unit is, because the baseline is important in determining how you handle patients like that. لو نرجع للبيبي what's your policy يعني what do you normally do for after you put a UVC? Do you put UVC in everybody or do you put UVC in some babies, specific weight or specific condition? And how long do you leave it? لو ممكن تقول لنا دكتور أسامة يعني and it's probably typical of what happens in all other hospitals.
Dr. Ivan.
If the baby anticipating to be sticky to our NICU for a long time, for more than 2 weeks, I think every baby will have a UVC or a PICC line. If he is anticipating to be of short duration, like 1 week, I think peripheral lines are more preferable in our NICUs.
Okay. And who puts the UVC, who puts the PICC, and who puts the peripheral IV?
UVC put by doctors, by neonatologists, and peripheral IV lines by nursing staff.
Okay. With PICC?
PICC lines by neonatologists.
Okay. And do you have TPN or you just do IV fluids?
Of course, TBN will be started if the baby is anticipated also or expected to be a long time in NBO.
Okay. So, for example, the baby you mentioned, would he get fed in the first or second or third day of life, like get breast milk? Or would you give him formula, or you wouldn't feed him for the first few days?
My baby, I will start as early as possible with expressed breast milk. At first 5 days of his life, he was on nasal CPAP. He was hemodynamic stable, so breastfeeding, which is rich with oligosaccharides, probiotic, prebiotics, will enhance the immunity. So I will start it, and I will postpone TBN in this baby.
Okay. Does the mom come to the hospital, or she goes home, or what happens?
We depends on expressed breast milk.
No, what happened to the mother?
Yes, the mother.
She goes home in the next day, right?
Yes, yes.
Well,
okay.
If you excuse me, it depends on the hospital itself, because we have a diversity of types of hospitals. There is obstetric and NICU hospital, then another hospital with NICUs without delivery, there is and so on. So it depends on the place itself, the facility itself. The policy changed according to the place.
كويس. طب هل الأم مسموح لها تيجي تزور البيبي في اليونت ولا ما تقدرش تيجي البيبي؟
No, she can, of course, she can.
Okay.
Well, we have adopted this policy since a few years with a lot of obstacles from nursing.
Exactly, yeah. And as far as I know, it's really hard.
Yeah, it was hard, but since maybe 5 or 6 or 7 years, we adopted this policy. It's accepted now.
Great. طيب هل الأم بديها مثلا breast pump to use أو bottles أو how did she bring milk for the baby?
Whatever the way she can. Sometimes we have a pump in some units. Some units don't have. She use manual or the simple suction devices. It depends on the facility itself.
Okay. But hey, the point and احنا would see what is it that we do now, and is there simple ways to improve, and what we can learn from other people what they did. مثلا اليونت بتاعتكم moms can come and visit, and يعني as far as I know many of the units moms cannot visit. It's an issue. How does the mom pump or help her with bringing milk? Support. الحاجات دي مش سهلة طبعا. So back to the baby. So there is, with a preterm labor and preterm rupture of membranes that happen with this baby, you have high risk for infection. And 15 to 25%, there is a maternal infection that predisposes or starts the preterm delivery process. This is reasons. So obviously with bacterial infection, there is increased prostaglandin in the amniotic fluid, and that stimulates the early labor. It can be ascending infection from the genital tract, or can be hemodynamic, and can be also coming from a body cavity, less likely, but can happen. So the nosocomial infection is the main thing. So I think we'll skip to go there because this is what we can do something about. So for example, this baby received 5 days of antibiotic. How long does it take your microbiology department to give you the result of the blood culture?
It also depends on the equipment available in the hospitals.
Exactly, yes.
Some hospitals provide an initial result after 2 days, it's the gram positive or gram negative. Some hospitals after 5 days.
Now, when can
Unfortunately,
it say negative blood culture, you can stop antibiotics?
Most of the hospitals after average 10 days to 14 days.
Well, exactly. So, yeah. Okay. Do you also have term babies admitted to the unit with antibiotics because their mother had a fever or had a prolonged rupture of membrane?
The baby is well and is doing well with can have his feeding well. They will not start antibiotic.
So term baby, mom has a fever, rupture membranes more than 18 hours. You wouldn't give antibiotic. You would just feed the baby.
Yes.
Okay. In the United States هم بنعمل chorioamnionitis diagnosis is dependent on the obstetrician. يعني احنا criteria for chorioamnionitis is available, which is premature rupture of membranes, maternal fever, maternal leukocytosis, uterine tenderness, purulent discharge. The obstetrician does not have to apply all these criteria. If he says this mom has chorio, it's chorio. But we admit the babies, and في حاجة دلوقتي اسمها sepsis calculator for babies who are not symptomatic. They have no symptoms. We plug in the numbers for what are the risk factors and what's your baseline sepsis. So the less likely there is sepsis, the baby may not get antibiotics. But if you have high baseline sepsis rate, the baby will probably end up getting antibiotics. Well, if the mom has chorio, the baby has to be assessed and mostly admitted to the NICU and getting antibiotics. There is some separation. This is what we talked about in the beginning, that if you work up the baby for sepsis, you give him antibiotics, you separate him from mom, because the baby has to get that in the neonatal units to be monitored, to be assessed, to make sure the IV is good. The quicker the blood culture results can come back, the less time the baby spends in the NICU away from the mother. فالحقيقة يعني أنا اللي أعرفه إن فعلا زي ما أنت قلت كده على حسب الميكروبيولوجي لاب بيعمل إيه. ممكن 5 أيام، ممكن 7 أيام، ممكن 12 يوم عشان الميكروبيولوجي يقول الكالتشر is negative. But this period of time you have to decide, do you give the baby antibiotics or do you just observe or do you send the baby home? Tough questions, and if anything bad happens to the baby, it's your responsibility. فالادفانسمنت اللي حصلت في مثلا في الدول الغربيه والدول الخليج حتى ان البروسيسنج اوف بلاد كلتشر دلوقتي في ميديا وفي اوتوميتد سيستم بحيث ان خلال 48 ساعه 98% of the organisms that are going to grow will be found. If you have a blood culture or you talk to your microbiology and get bottles for blood culture that will grow your organism in 48 hours, it will save the baby stay in the hospital. It will save money from antibiotics that you don't have to give. And you send the baby home to his mom sooner. It's investment, and you have to update your microbiology. You probably have to bring them blood culture bottles, media. هتبقى مكلفة بس ممكن to save money on the other side. يعني لو انت مثلا عندك baby، طبعا these are to the asymptomatic baby. Your baby has to be admitted. It's a premature baby, 1.8 kilo, has respiratory distress. He needs to be admitted. But how long do you give him antibiotics? يعني if you have a blood culture that grows in 48 hours, then you don't need to give them for 5 days. So that saves money. It's less antibiotics. Also, if you don't need to give antibiotics, you may not need the line. If you give the baby some feed and he's tolerating the feeds, then you don't need your UVC. So it's worth thinking about. يعني ان انت to invest in microbiology وتوفر في ال NICU. لأن المشكلة كمان في مصر ال NICU beds are not that much available. And I'm sure you get calls of parents, their baby needs ICU bed, NICU, and you cannot take them because you don't have beds. So this will allow you to take care of the babies who really need an ICU versus who someone does not need as much antibiotics. So back to the nosocomial infection, which is the responsibility of the medical team. So most commonly is Staphylococcus infection. And that's mostly associated with central lines. The nosocomial infection, or now they call it hospital-acquired infection. If it's associated with central lines, now it's in a category by itself. It's called CLABSI, central line associated bloodstream infection. How do you minimize the chances? Okay, your baby had staph coagulase negative infection, correct?
Yes.
Okay, could that have been prevented? And then you also, after you got the infection, you had to intubate him, you had to stop the feeding, give him antibiotics for 7 days. So could we have prevented the staph infection?
Yeah, of course. I think first question we have to answer is this baby really need a central line or umbilical venous catheter or not? Then the moment we insert it, we should have a clear plan when to remove it and remove it in very short time, in the appropriate time. Every day we have lengthened the insertion of UVC. Will increase the risk of latent sepsis.
Good. So these are all great points. So not to put it in if you don't need it, and to remove it as soon as you don't need it that much anymore. However, meanwhile, he's getting fluid through the umbilical venous catheter. فدلوقتي في حاجة بيعملوا bundles، لأن مثلا كل حاجة من دول لوحدها كويسة. لما بنعمل حاجات كتيرة في نفس الوقت, you get a much better result. So it's a bundle of procedures that you do. So you think about, do I really need to insert it? Can I remove it safely today? But more importantly, how do you connect your fluids to the catheter? And this seems to be the main issue. فدلوقتي مثلا البندل دي it's available online, يعني it's not a secret. ازاي النيرسز, لان دي nursing procedure, ان هم ازاي connect your fluids to your line. انت هتدي antibiotics, الantibiotics دي هتديها through the line. فانت you have to disconnect the fluids, connect your antibiotics, give it, stop, remove, disconnect. This opening and closing and connecting, that all is a risk for infection. And that's most likely how the baby got the coag negative staph. Also, how clean is the site of the insertion of the catheter. مثلا مغطينه بdiapers والdiapers مليان urine and stool, ولا it's exposed and clean and we check it. سواء في umbilical catheter, طبعا لو PICC line انت you put the dressing, بس برضو to check on the dressing, is it clean, is there blood, is it red. فدي process of handling central line دلوقتي بنسموها bundle of care. ده لما بنعمل حاجة زي كده بنقلل احتمالات infection from nosocomial, from us as the medical team. the timing of the infection, and usually it's the late infection problems. You've had all these with your baby: respiratory distress, temperature instability, abdominal distension or feeding intolerance, hypo or hyperglycemia. Then he becomes hypoperfused, tachycardic, have metabolic acidosis. When it gets severe, things are much worse. Luckily, your patient did not have that. And then they would do the evaluation just like exactly what you did. You will do the CBC. You will do check for left shift or immature to total ratio of neutrophils, X-rays, and blood culture, and PCR. Or if there is a specific organism you're looking for and it's hard to grow in a blood culture. Now, حتى الستaph epidermidis used to take a long time to grow. دلوقتي newer blood culture, within 48 hours, if it's there, it will grow. Even the fungal culture, احنا في neonatology بنبعت one culture, aerobic, anaerobic, and fungal, with about 1 ml of blood. طبعا the more blood you have, the more likely you'll grow the organism, بس يعني 1 ml is generally good. Adults, well, big people, they usually send 2 blood cultures. Criteria are a little different for neonatology. فهو 1 ml in 1 blood culture will grow whatever organism that is there in the baby. IT ratio بنعملها كتير. CRP كويس ان بتعملوا ال CRP او however the cut point is important لان ال sensitivity and specificity of CRP for infection changes with what cut points do you take. The higher the number, it will be more specific and less sensitive. You probably can see how that helps, but the CRP goes up 12 to 24 hours after the infection. You may need to delay it a little bit, so it's more helpful for trending recovery rather than to start antibiotics or not. And start antibiotics or not, you need to decide once the baby becomes sick. For lumbar puncture, you brought up the issue, should we do lumbar puncture or not? In most places, when we start with the sepsis workup, we don't do lumbar puncture unless the kid presented with seizure. We can delay the lumbar puncture, but then you need to get a good one to look for cells. And if you're treating with antibiotics, you may not grow. But if you're looking for cells, if you have high white count, then you know there's meningitis, and then you need to adjust your treatment. You have to treat for longer. You have to you may need to make changes in your antibiotics. However, if you only have staph epi, generally it does not cause meningitis. When do you stop? So you start once you suspect, but when do you stop? So for gram-positive, it's about 7 days. Gram-negative, it's 7 to 10 days. And the sooner you stop, the better it is. فمثلا في places عندهم antibiotic stewardship program. لو انت ابتديت حاجة مثلا زي فانكو أو سيفتازيديم أو سيفاتوكسيم، لازم infectious disease person follows up with you and make sure that you stop it when it's no longer needed. هل لسه في سيفاتوكسيم أو كلافوران في مصر ولا برضه مش موجود؟
موجود يا فندم.
اوكي. هو الشركة اللي بتعمله هنا في أمريكا بطلت تعمله. بس ممكن طبعا في شركات في أوروبا وفي كده. هو مش مضر يعني، بس الشركة قررت إنها مش هتعمله يعني. طبعا أنت كدكتور taking care of a baby who became sick, now he's better. You don't want to stop the antibiotics. You want to give it longer to make sure that the baby stays good. However, the right thing to do, because longer antibiotics is not good for the baby. You may have fungal infection later. You may, as we've mentioned, there is higher obesity. You're changing the bacteria that's normally in the baby. One of the issues about this microbiome is that in babies born by C-section, they don't have the same, healthy babies, they don't have the same bacteria in their GI tract that are babies born vaginally. It's an issue for how many babies are delivered by C-section. That's one of the criteria for hospitals to monitor the rate of their C-section. If their C-section rate is high, they have to look into it and see why they have a high C-section rate. So C-section rate of 10% is about average, 15% if you're in a high risk obstetric service. So if you have a rate of 25, 30%, you have to have a reason why you have so many C-sections. Then it's not good for the mom, it's not good for the baby. It's important to see what we're doing, even though the baby looks okay, mom is okay, but can we do better? So we've actually have gone through most of these issues. This is evaluation and management of possible neonatal sepsis of more than 35 weeks. This is available from the CDC. متهيألي ما اعرفش انتوا اكيد بتتابعوا كوفيد والCDC recommendations بتاعت امتى التست وكده، بس يعني CDC في امريكا حاجه كبيره. We دايما follow the recommendation of the CDC. فده it's a flow diagram. It looks busy, but it's easier to download it. الميزه ان حاجات الCDC دي كلها free. يعني you just go on their website, you search what you want. So this is evaluation and measurement of possible neonatal sepsis, more than 35 weeks, and you can download this. So can we prevent infection? So this is over years in the United States, and you can see the rate of infections, it goes down. And that's because organizations are interested in this issue by the issue statements. Then the CDC comes up with guidelines. Then we practice these guidelines. So the infection rate goes down. So it's a preventable infection. We're not going to get to zero, but you can go from 1.5 2 per 1,000 live birth to less than 1. So you can make a major impact. This is from McMaster in Canada. And what they did, they say, oh, our rates are high. They keep going up and down. Can we do something about it? So they form a team to look at how they can prevent infection in their NICU. And you can see over time. So it's not going to be magic. You're not going to say, okay, this is what we'll do, and everybody will be in compliance and will perform perfectly. It will take time, but it will come down. So that's the importance of thinking about this as a team effort. Nursing is very important, doctors, everybody who works in the NICU, how you clean the place, what's your policy for moms. So it has to be a new working group, a new team comes together and decide, okay, how are we going to decrease that? So your baby, you did wonderful for the baby, but the baby had an infection that she didn't have to get. So can we prevent that? So you need a team. It has to be interdisciplinary nurses, because it's the nurses who do most of the touching and contact with the baby. Okay, how many infections did we have this month? How many centralized with these late ones? Why did we get them? Can we do something about them? So you need monthly monthly meetings, written down. Okay.
لو في موبايل حضرتك داخل موبايل عشان بيسحب برضه الباقة. لو حضرتك داخل
لا أنا عندي الواي فاي
واي فاي اوكي
من الكمبيوتر.
طب كويس اوكي.
الفكرة ودي بيعملوها مش بس للانفكشن بس، طبعا ده موضوعنا النهارده. for improvement بنعمل تيم نيو جروب، دي تبقى دي the responsibility, then they would want to have results. multi-professional, multi-disciplinary. الانفكشن ريتس النهارده كذا، عندنا جول ان احنا مثلا بعد ست الانفكشن ريت وهننزلها بواحد اثنين ثلاثة أربعة في monitoring we're accountable to the plan. فدي في ال ICU بالذات مهم الموضوع. Central vascular line bundles لأن يعني النيوناتولوجيست بيحطوا UAC والUBC في العادة مش مشكلة، وزي البيبي بتاعكم third day of life which would be related to insertion got sick at 7 days of life, which related to maintenance, not to how you inserted the UVC. The UVC was great. We enforcement of your unit policy by communication, sure you have good hand hygiene. Everybody's doing a lot of hand hygiene these days عشان الكوفيد، ده المفروض نستمر فيه حتى بعد الكوفيد، يعني يبقى فيه good hand hygiene. This is really important. تبتدي الفيدز بدري زي ما انت قلت دكتور ايفن، ان الموضوعات how do you store it, how do your mom brings it in, how moms visit, this available everywhere. يعني it's always a problem visitation لان دايما النيوناتولوجيست أو مش عايزين visiting في ال NICU لأن So no third generation cephalosporin. You only treat sepsis, do not treat colonization, and shorter period of time, the least spectrum. You can skip this. So good antibiotic practice. So stop antibiotics if culture is negative. So the earlier you get the culture, the earlier you can stop your antibiotics. So I would think it's probably worth the investment. These are some excuses. So raised CRP, is it coming down? Contamination, and we don't have the result of the blood culture. So you're already doing this. This is some pictures of how a central line device can cause infection. It can introduce infection to the baby. So insert it only when needed, remove it when we can do without it. It doesn't have to be perfect. The baby doesn't have to be on full feeds. This baby is getting 100 ml per kilo per day. That's good enough. Sterile technique, minimize manipulation of the catheter. So this is a nursing important part, is that, okay, we have to give this baby this antibiotics. So we have to start new fluids. So let's do it all at one time. So we clean everything, do it at once, and then leave it alone. Okay, so we can stop now. Prevention is important, and thank you for this presentation. I hope that some of the ideas we can use is to decrease late infection. Okay, thank you, Dr. Evan. Thank you, Dr. Hassan.